how can you do actually more with less? Spending less money, but perhaps, being able to deliver more in terms of access of health products to patients.
It may be inconvenient going to a store looking for a particular product and coming away empty-handed. But if the item you need is a healthcare product, the situation becomes dire and could be the difference between life and death. Welcome to another episode of Inside Alvarez Business, a podcast dedicated to bringing you the stories behind the research. I'm your host, Jonathan Helbesleben, Dean of the Carlos Alvarez College of Business at the University of Texas at San Antonio. This season, we're focusing on the business of healthcare. We're sharing the stories of our faculty, the real-world impact of their research, and what led them to study these important topics. Our guest today is Amir Karimi, an assistant professor of operations and analytics in the Alvarez College of Business. Amir studies how logistics and supply chain issues impact healthcare globally, particularly in low and middle-income countries. Listen to hear how small changes can lead to dramatic outcomes across the globe. So, Amir, welcome again to Inside Alvarez Business. Looking forward to hearing the stories behind your research. So, to get started, I'm always interested in how people got into their academic careers. I mean, as I mentioned to previous guests, like nobody grows up thinking, I'm going to be a professor. Like that's not very common. How did you get into what inspired you to become an academic?
Yeah, that's an excellent question. I feel like, so I grew up in Iran. And, I think the way universities work in Iran are probably a little bit different than maybe what Americans are used to. Mm-hmm. It's not necessarily that you're following your passion. I think it could be more so that maybe some trends you may follow. Like people, I think typically so first of all, there's like a nationwide entrance exam, which is very competitive because to get to the best schools, you need to study hard and whatnot. Mm-hmm. But then when it comes to selecting where you want to go, like typically I think people just start with engineering, let's say electrical, computer, mechanical, without even knowing actually what those subjects are all about.
Oh, interesting. Okay.
Yeah. So they could actually get into it and they may feel like, this is not actually something that I may even like, right? Yeah. So for me, I followed the typical, pathway, entrance exam. So I ended up with something that was called industrial management.
Okay.
So not engineering. So I feel like actually most probably Iranians that you find at schools in the U.S., like they've come from Iran. I think most of them have some engineering background. So I think mine, I guess, is a little bit different. Has some similarities to industrial engineering, but I think there has bigger focus on business, I would say.
Okay.
They cover like industrial psychology and some of these other topics.
Okay.
So then for me, there was a stage in time where I felt like it would actually be kind of cool to get a little bit of exposure to see what is also happening outside Iran, and explore opportunities. So I think this field, like supply chain management, operations management, was the natural fit given my background.
Okay.
I think that's how I got into this field, but I did not really envision like the possibilities that lie ahead.
Okay.
So right now, I think I've found the niche topic that I really like.
Yeah.
I'm passionate about. I don't think I knew about it actually.
Okay.
Before getting into the field, like starting the PhD program.
Oh, okay. That's really cool. So you kind of discovered it.
Yes.
Like you decided to pursue the PhD and then you sort of discovered the passion.
That's exactly right. Yeah. And I thought actually a PhD maybe it's kind of fail-proof because they're going to fund me. It's funded. Most PhD programs are funded in the U.S.
Yeah.
And if I end up not liking it, I mean, I can just, I guess, always go back home. That was my vision,
Okay, great. So, and then, and maybe this fits with the you mentioned about the passion and discovering that, but a lot of your work, or really, I guess, all of your work has really been around the healthcare industry. And how did that become the area that you focused on?
Yeah, excellent point. So, and again, as I started exploring, which I think a PhD program does a lot of pressure on you to find a topic, and I was exploring different things, what is feasible and not, but like from very early on, I felt like pursuing the bottom line, it's not necessarily my passion, and I can't force it. If it works for other people, which a lot of people in a business school may do, right? Mm-hmm. It was not something I wanted to follow. I wanted to do something that has a meaningful impact on people, communities, societies. Mm-hmm. So the focus of my research is actually low and middle income countries. Mm-hmm. So that's I can probably have the most impact, also given my background being from a low and middle income country, Iran, right? And also health. Health is an aspect, has a, I guess, personal connection to people. If you feel healthy, unhealthy, I mean, that's probably the most important, I guess, part of our life that is taken for granted because.
Yeah, it impacts everyone.
Yes.
Okay. Great. So so I'm seeing, thinking about your work and seeing how those two things are intersecting, and that's really interesting. And that you sort of discovered through your PhD program. That I mean, there's a personal connection, but kind of discovering that is the connection and
Yes.
that is the passion. It's kind of what happened in grad school.
That's exactly right.
Yep. Were there people in particular that inspired that?
So I think my advisor was open, which was good, like, and encouraging. Exploring maybe uncharted territories. Like the area I picked, I felt like it was something a little bit unusual. And maybe we'll get to this, I'm sure, in a bit. But it's an area, where, first of all, I wanted to do empirical research using data. And there's actually not a whole ton of data available there.
Yeah.
Just because, weak infrastructure and data may not even be collected to begin with.
Right.
So actually one of my advisors kind of cautioned against this, that, hey, this is not... It may not be something that you can actually do some rigorous empirical work here. But I mean, like, I think the other aspect about being successful in a PhD program is perseverance. Like if you just get discouraged by, I don't know, one comment here and there, then you're kind of done. But I think if you show perseverance, I feel like it may not always work, but at least you give it a chance. So I feel like in that case, it did work out. I did end up finding, a couple of data sources, which led to one publication. And then like a few others actually also followed. But now I'm at a stage where I actually see just a ton of opportunities. I just don't know which I have to prioritize now,
Yeah. Sort of open one door, but
Yes.
then that opens so many more.
Exactly.
Well, that's really cool. Let's talk a little bit more specifically about your research, because and I want to come back to that data thing, because I think that's really, really interesting. You've got a topic that almost by definition makes the data a little bit trickier to come by. So a lot of your research examines the notion of stockouts, in particular of healthcare products, and of course, especially in developing countries. Can you help us understand what a stockout is and why that's so problematic?
Yeah. Excellent question. And I actually do talk about this in the course that I teach also at the Alvarez College of Business, because I think it is a phenomenon that is very relatable. So I think it's something that we may have all come across. If you go to H-E-B or Target, you're looking, I don't know, to get maybe a, let's say, bag of popcorns or, some ice cream or something, right? And if it happens to not be on the shelf, you could potentially end up leaving the store empty-handed, right?
Yeah.
Which is inconvenience for sure in this case. So, but when we talk about health products, so there are a whole set of other consequences that actually emerge now. So imagine a client walks into a health clinic, a pharmacy, and they're seeking a particular type of health product. Let's say in this case, contraceptives, maybe HIV medication, right? Antimalarials. And the product happens to not be on the shelf.
Yeah.
So that is the essence of the problem. It's out of stock.
Yeah. It's not just inconvenient. It's
Yes.
perhaps quite problematic.
Exactly.
Yeah.
Yeah.
Okay. And I guess in some ways it makes it kind of obvious why it's so problematic. And this apparently is a pretty common phenomenon. I mean, I know for a lot of folks, we think about it and we think of it as an inconvenience, but the abundance, for me, this is going to sound really silly, but for me, it was lemon pudding. When I was in Alabama, it seemed like we would go shopping and there was never lemon pudding, and we wanted to make a lemon meringue pie. And I was like, why can't we find lemon pudding? But it really wasn't that big of a deal. We just had to go to a different store. That's not going to be as likely for both a healthcare product and I suppose probably the context that you're working in.
That's exactly right. So like in this example, for example, you could have actually walked a few miles or something to reach the health clinic.
Right, to find out.
And you may actually not even have any alternatives, You may not be able to afford like spending that much time and money to come back again. Or simply, you could just be discouraged. You were looking for something, you didn't find it, and, you may just not come back to it again.
Yeah. Okay. So from the work that you've done, I mean, and you've kind of explored this from different angles. So, I mean, if you had to kind of summarize what causes these things, and kind of because of that, what kind of things can healthcare organizations be doing and thinking about to maybe try to avoid the problem?
Yeah, that's an excellent question. And I think the answer is not, that straightforward because it all relies on supply chains. So let's think about the supply chains for contraceptives. So the patients, the client, they may see the actual product at the clinic, but actually it takes a long journey
Yeah.
until that product reaches that point, which is also the case for any other product, ice cream or popcorn or lemon pudding.
Yeah. That was the problem.
Yeah. So first of all, there's manufacturing of contraceptives, which for the most part does not actually take place in LMICs. It's because I think that the process in some cases could be complex. I think condoms, those are a bit easier to manufacture locally. But like when it gets to like vials or injectables and when the process becomes more complex, that is where you don't see actually local manufacturing of contraceptives. So it needs to be manufactured somewhere. So that means it needs to be shipped,
Yeah.
right? Who's going to pay for it? That's again another tricky question. So in the past, like donors have taken responsibility for that, maybe USAID, the Global Fund, but we see actually that being also vanished.
Yes.
So who's going to pay for it again? These are all factors that actually impact stockouts, right?
Yeah.
Because down the road at the clinic may impact whether people are going to have access to it or not. So procurement, that is one factor. But even if you actually manage to pay for it and bring the supplies into a country, let's say the national warehouse, it is still a long journey until it reaches the patients.
Okay.
Because long distances, let's say you're in the capital, for example, it's going to take a long distance until that product actually reaches other stores. And add to that also a lack of road infrastructure.
I was just going to say
Yes.
the infrastructure, there's the distance, but
Yes.
Distance in the United States might be different than distance in these countries.
Exactly.
Not the infrastructure.
Which I think is actually one of the differences. I feel like here, maybe in Texas or anywhere else, I think if you travel from, let's say, the metro area, maybe to a rural area, I don't think you see a whole ton of difference in terms of like road infrastructure.
Yeah.
It pretty much remains the same, in terms of, you see, like still it has paint and the road signs and all that. That's not necessarily the case actually in when we talk about low-income countries. So it could become a lot worse. It could become, maybe unpaved roads. And these are all things that actually matter in terms of logistics and supply chain management.
Yeah. Yeah. So is there anything that, some of these providers can be doing to help avoid the problem of stockouts?
So that is a great question. So I talked about procurement. The distribution part is tricky. But even when it comes to the clinic itself, so these are products that you actually need to manage on a day-to-day basis.
Yeah.
So let's say you're a nurse, you're a midwife, we're working at a clinic. So this is also something that I have observed in my research, which is kind of interesting. So as a nurse, it is not just your responsibility to actually care for the patients. Patients arriving, maybe taking vital signs or administering maybe some IV medication. But interestingly, actually, these nurses are dual tasked. They also need to be in charge of inventory management, which they may not actually know a whole lot about.
Yeah. Interesting.
So in one of the research studies that recently completed, actually, we found that if you give these nurses the training they need to be able to more effectively manage inventory, it's going to have a demonstrative impact on reducing stockouts.
Yeah. Yeah. It's interesting you bring that up because I made some notes in part because I think it's actually sort of worth sharing the impact. So, and please correct me if I'm wrong, but that frontline training, you translated that to saving 4.25 maternal and newborn lives per 100,000 women of reproductive age. And so just my napkin calculation, because this was a study in Indonesia, my napkin calculation, that would be 1,600 lives saved just by training the frontline nurses. And then interestingly, it more than doubled if you did the training in person.
Yes.
That's really fascinating.
Yeah.
I mean, I'd like to think that would be enough to convince people that you ought to do this.
Yeah.
I'm guessing that's not enough to convince people.
Yeah.
I mean, it's still not happening necessarily, but.
Right. Because again, I think it goes back to, I feel like resources, and this is actually one of, I guess, the key messages of the paper is that, if you could do the training to everyone, even if we don't know that there is an impact. I mean, what does it hurt, right? Let's just do it. If there's no funding constraint. But unfortunately, again, in any context, I think funding is going to be a constraint, but especially when we're talking about low income settings,
Right.
there are a whole host of other priorities, right? Why should I spend money on some training that I don't even know what the impact of it is, right? So I think this is where I feel like the research also sheds some light. So it is about how can you do actually more with less, with spending less money, but perhaps being able to deliver more in terms of access of health products to patients. So what you mentioned is exactly right. We did see that if you do the training on site inside a health clinic, where a trainer actually goes to the actual place where the nurse is working, I think the impact is about 5 times or something greater than if you gathered a bunch of nurses into a classroom and gave them the training there. So I think that also shows the impact of some sort of experiential learning.
Yeah.
We also emphasize a lot in our classrooms and in teaching as well.
Yeah. Well, and I imagine that I mean, and maybe your studies haven't gotten to this point, but it seems to me, so I'm thinking from an industrial psychologist's perspective, but being able to see, I mean, it's one thing to kind of grasp the concepts, but, and maybe even see examples of it. But when you see it like on your shelves, that seems like that would have a very powerful impact. You can get a little bit better sense of, the quantity and what it looks like on your shelf versus that same quantity might look very different in a different setting.
Yes, you're exactly right. So I think you're talking about tailoring the training actually to what each health clinic may need. Because a clinic, the storage area may look very different, depending on the clinic. So if you tailor the training to a specific setting where the health worker is actually working, rather than some generic environment, it's like a classroom of some sort that, looks nothing like where I do my work.
Right.
That's where you see the most benefit.
Okay. That's really interesting. So let's actually go back to something we mentioned before about in terms of the data, because to me, I was, like I said, I hadn't thought about it until you said it, but really is one of those unique research problems that we sometimes see where the very nature of the problem makes it hard to study, in the sense that, I mean, if you've got a system that's just plagued with stockouts, they probably have some other challenges in terms of, there's probably not somebody keeping very close track of when those stockouts happened and how long it took to get the stuff back. How do you study that?
Yeah, I think it is tricky. So in some instances, there have been surveys that were conducted, and these are massive surveys. So think of it, a national survey that takes actually 2 years to complete. There's these surveyors that go to each health clinic, and they have this long list of items in terms of questions, right? And it's not actually just stockouts. Stockouts is only like a tiny proportion of all the questions they ask, because there are a whole host of other things that are also happening. Do you have access to electricity here? Is there clean water at the clinic or not? I don't know, like, what is patient satisfaction here? How does that look like? So stockout is actually only one of them. So this was one way that I did study stockout, through one of these surveys.
Okay.
These massive surveys, which was, I don't think funding, maybe it was actually the funding that is provided by USAID, but USAID does provide a lot of, or did actually provide a lot of help in terms of administering these surveys. So I hope this can continue in the future as well, and we're not going to lose access to all of these valuable data.
Yeah, I hope so too. I wish I could say I was optimistic, but I hope so too, because I can see that, that would be something, the data collection certainly would be something that would be one of the, I don't want to say the first to go, but, certainly wouldn't be as high a priority as actually providing the aid, for example. So far you've studied, I know, several different countries, and I know your focus has been on kind of the lower income countries. Are there lessons that can be learned from that could help improve things in the United States?
I think the core of issue also goes back to probably, I feel like, disparities in terms of disparities to access. So I'm just going to mention a couple of numbers. So something like unmet need for contraceptives, which is the percentage of people who need access to contraceptives but are not using it for whatever reason. In some countries in sub-Saharan Africa, it could be up to 40%. So in the U.S., it's actually, North America, maybe it's around 6%.
Oh, wow. That's quite a difference. Yeah.
But even within, so that is actually the average number. But in the U.S. still, and also within like low-income countries, there's another, level of disparity. Not everyone is going to have equal access.
Right.
So and that is what I have also seen in my research as well, that like stockouts, for example, is not something that is happening like proportionally or equally everywhere in the country. There are places that are going to suffer a lot more. I feel like that is probably going to be a factor to consider anywhere you go. Like in the US, for example, maternal mortality, the US actually has one of the higher maternal mortality rates among the industrialized nations. I think it is twice or three times as high as those countries in Europe or Canada. But even in the US, so who's suffering most actually from these maternal mortalities? It is African American women. Like that number goes like 5 times higher than the average for those individuals. So I think looking at the disparities, I feel like that could be another, I think, important takeaway in terms of improving access. Like these are essentially marginalized communities, neglected, whatever terminology you want to use.
Yeah. No, that makes sense. So in some ways that could give us a little bit of hope here in the US that, as you're learning things about things that are happening in other countries, there is that parallel. I think about work I've done in the past with rural hospitals and some of the challenges they have. I've never looked at stockouts, but I imagine they're higher in some of those rural hospitals as well. In part too, because some of the stuff expires, so they're not going to want to keep a ton of it if they don't want to keep what they need, and so but then that puts them at higher risk of a stockout. So that would be interesting to kind of translate some of that and see how that works. So through the pandemic, stockouts were kind of a big problem everywhere. The toilet paper stuff and all of that. Has that opened up some different possibilities for you in terms of research, or maybe not because you've been kind of focused on the one context?
Yeah, I think for sure probably it made the field of supply chain management a lot more relevant. I think
Yeah, really.
Now, like if I mention shortages, I can just bring up this toilet paper example because I'm sure like majority of people experienced it maybe firsthand or heard about it one way or another. Or the shortages of the PPEs, the personal protective equipment for nurses who are fighting the pandemic. So I think it for sure has made it easier for me to talk about my research, and also like has elevated, I feel like, the field of supply chain management a little bit. But in terms of research, this is something actually I've thought a lot about, and I have had thoughts about what is the impact of pandemic on different outcomes. I don't have like, I guess, a working paper or something at the moment, because I think whenever you're doing academic research, I feel like the expectation is that you're expected to uncover something maybe surprising or you did not expect, right? So if I come out and say that, yeah, the pandemic did lead to an increase in stockouts, I feel like, I think
of course, yes, it did.
They're not going to be super enthusiastic, I guess, about it, unless I cover something. If it did reduce stockouts, maybe, that is something that would be
counterintuitive.
Yes, right, exactly.
Yeah. I do think there's still maybe there would be some interesting and maybe even counterintuitive things looking at the how they happened. It'd be different than the healthcare thing though. So, like why in the world was it that people were stockpiling toilet paper? It's just weird. Yeah. So I guess maybe like the psychological components, maybe there's some counterintuitive or interesting things there. But I see your point that everybody pretty much knew they happened.
Exactly.
And so,
but one point that's I think interesting that I've also thought about, probably looking at productivity. I think that could be something interesting to study. It's not exactly my topic of interest, but I mean, think of like the COVID pandemic, and it's a debilitating disease, and it once you catch it, you could catch it again, right? And I've actually read a lot of like health journals that talk about this. It is not just the flu, because it impacts, your body in so many different ways. The nervous system, like when you lose your sense of smell, or when you have brain fog, and all these are like all signs that this disease is impacting your body in different ways.
Yeah.
So I would actually be curious to see like how many days of, productivity had just been lost, or people who are now struggling with long COVID.
Yeah.
And are also being dismissed by doctors because they don't even know, what the solution to that is.
Yeah, yeah.
I think that would be an interesting research question to study.
Yeah. That kind of reminds me, sort of a related possibility too, that might come up sort of from time to time, but I think it's mostly resolved now, but there was a period maybe 2 years ago where there was this massive shortage of ADHD drugs.
Oh.
And so that could actually be interesting to kind of take a look at. Did we see differences in productivity or learning for students, that type of thing? I don't know if it was enough of a shortage to have that impact or not, but
Okay.
I can see how
Yeah.
translating the stockouts to productivity could be really interesting.
I need to look that up. ADHD drugs.
Yeah, I think it was like maybe 2 years ago.
Oh.
So. Okay, well, let's see. So a recent paper that you published in Production and Operations Management took a bigger picture angle, and you explored how female decision makers that were serving either as health ministers in a country or in their governing body, like a parliament, impacted procurement of contraceptives. What was the inspiration for that study? Because it's kind of a little bit different angle from what you were looking at before.
Yes, it is. And it is more of a big picture kind of. So it's not looking at availability of contraceptives at the clinic level. So it's looking at actually national procurement of contraceptives, like at the high level.
Yeah.
And so I'm going to actually give out a couple of numbers. So these are things I've read, across different reports and articles. I believe 80% of the frontline health workforce, nurses and doctors and midwives, are women. So 80%, like think of that. That's a massive number, right?
Yeah.
So these are the people that are actually delivering care and like all of that essential stuff. They did that during COVID-19, which was an emergency crisis, but they're also doing it in non-emergency time on a day-to-day basis,
Yeah.
even if we don't hear about them. But when it comes to who's actually making decisions, making policies in terms of health,
Yeah.
it's only, I think, about 15 or 20% or something on average. In some countries, it's going to be less. Some countries are going to be more.
Right.
I mean, like, if you want to think about parity, like if 50% of the population is female, I mean, 50% in terms of decision making, that would make more sense. But especially if you have 80% of the frontline health workforce, those are the people who have actually the knowledge. They have firsthand experience in terms of dealing with patients, right? So there's something, that is not quite right.
Yeah. It doesn't line up.
Yeah, exactly. So then the question becomes, so what happens actually if you have more female decision makers making these types of decisions related to health? Are they going to make decisions that are going to benefit women more? Are they going to be, impartial, or what are they going to do? Yeah.
Okay. And what'd you find?
And what we find, we actually confirm what I just said, that when you have more women as health ministers, when you have a woman health minister in a country, we have ways of dealing, with different sorts of biases in the analysis. When you have more women as health ministers, they do increase the procurement of contraceptives. If I remember correctly, I think it's about by 60%. So you're going to order 60% more contraceptives.
Okay.
And so when you have female health ministers, but on top of that, you also have women as parliamentarians, these are also going to help the minister actually achieve their goals, because the parliamentarians are also in charge of allocating budget and all of that.
Right. Yeah, you might have aspirations to procure more, but if you don't have the money,
Exactly.
that's not going to happen.
So when you have both of these elements, the executive, legislative branch together, represented by more women, then there's even a greater increase in contraceptive procurement.
Okay, that's really interesting. That's really interesting, and certainly gives us food for thought as we kind of just think about representation across the country and across the world, and
Exactly.
the impact that can have. So, well, what's up next for you? What are you particularly excited about that you're working on that you're okay sharing?
Yeah. So we were trying to do a follow-up study with the Indonesia one. And the Indonesia study, by the way, was one where I did collaborate with an organization. It's called Jon Snow Inc. And it's been really fruitful. So it has taken actually a little bit of time, I think, to collect the data and all of that, because this was something I started when I was a PhD student, like back in 2017 or 18 or something. So data collection took some time, then coming up with a research design, because this was also done all in collaboration with JSI.
Okay.
So there are co-authors on the paper. So lots of back and forth, until we arrived at a good angle research question they also had interest in. So the paper seems to be converging now. How many years is it? I guess it's like 7-something years, right?
Yeah, yeah.
7, 8
I
years
guess
or
8
something.
years.
Yeah.
Yeah. Wow.
But there's a follow-up study there. And again, the study was about training. What happens if you deliver training to these frontline health workers such that they become more effective in managing inventory? So the question here in this follow-up study, which I'll be collaborating with JSI again, is okay, so training is great, but it's still, capital intensive. So in Indonesia, it was only about, I think, 10% of the entire cohort of health facilities in the country that were trained.
Okay.
So 90% were left untrained, even though if you could have trained them, it would have been beneficial.
Yeah, yeah.
So I'm trying to come up with some sort of machine learning, artificial intelligence model to see if we can transfer the benefits from those that were trained to the ones that were untrained, actually. Is there a way, like, without delivering additional training, is there a way to transfer those benefits or not? So that is, I guess, my next focus.
Yeah. Well, that's really cool. It's in a way, it sounds a little futuristic. It may not be as futuristic as is in my imagination, but
Yeah. Yeah.
for some reason, I'm thinking like beams transferring to people or something like this. But
Yeah.
but that does seem like a really great thought. Just to given, you're right. I mean, training is capital intensive. So if you've got a way that you can, make that a more efficient process and reach more people,
Yes.
we already know what the impact could potentially be.
Yeah, and what's cool, actually, the organization is already very supportive and seems like willing to engage in this project. So I'm going to meet with them and then see, what is next.
Okay. Very good. Very good. Well, having talked with you a little bit out in other settings, I know you are an incredibly busy guy. So I'm curious, what kind of stuff outside of the Carlos Alvarez College of Business do you spend time with?
Yeah, fun question. So my wife and I, we love gardening. So we live in the South Town part of San Antonio. It is right south of downtown. And so when we purchased this house, there's a lot of grass, Bermuda grass here and there, which I don't think does a whole lot of benefit, like to creatures and whatnot.
Yeah.
Bees and birds, they're not going to benefit from that. So,
Yeah.
but we did transform both our front yard, backyard into essentially native landscaping.
Cool.
We did a lot of work on our own. So purchasing the plants, planting them, water, and all of that. And now I think we do have a beautiful garden and it does actually invite a lot of different creatures. In Texas, we are a state where there's some numbers there. I think it is the most number of like migrating birds that pass through or something.
We're kind of along that path.
Yes,
Yeah.
exactly. So it's funny, like some of these birds so I graduated from Minnesota.
Yeah.
Some of the birds that we actually had to go like some far forest with binoculars or something, try to look for them in Minnesota. Now we actually find them in our backyard.
Yeah. Well, and you had to look for them during like that 1 week a year where it was warm enough.
Yeah, right.
Well, that's really cool. So you're attracting all kinds of interesting creatures, and then that makes it more interesting of a yard. That's really great.
And I think that is also good. I guess it's a good side gig as you're busy, with research and whatnot. If you want to take a little break, just go to a yard and maybe relax a bit. Yeah,
Absolutely. My wife is similar. She enjoys that kind of stuff too. More than I do. I mean, I help when I can, but it certainly is relaxing to her too, and I can see why. And that's great that you're also able to do that along with your wife. So that's terrific. Well, Amir, it has been such a joy talking with you here today. Obviously, as we mentioned right at the start, we all interface with the healthcare system. Health is an issue for all of us. So I'm glad to know that we've got amazing researchers like you that are tackling these important issues. And in your case, not even just here, but globally. And I hope you feel like you're actually making a difference with the work that you're doing, because I certainly think you are. So thank you for being here today. And again, more importantly, thank you for the great work that you're doing to improve all of our lives. Thank you.
Yeah, thank you for having me.
Thank you for listening to the Inside Alvarez Business Podcast. Special thanks to our producer, Brittany Johnson, and for the support of Wendy Frost and Melissa Lackey to help make this podcast possible. Stay connected with the Carlos Alvarez College of Business at the University of Texas in San Antonio to learn more about how we are empowering the next generation of business thinkers and conducting groundbreaking research to ensure their success. Follow us on social media or visit us online at business.utsa.edu. Until next time. I'm Jonathan Halbesleben. Thank you for listening.